Episode number 165 of the Wholesome Fertility Podcast. Welcome to the Wholesome Fertility Podcast. I'm Michelle, a fertility acupuncturist here to provide you with resources on how to create a wholesome approach to your fertility journey. My guest today is Dr. Andrea Vidali. Dr. Vidali is a world-renowned endometriosis surgeon, reproductive immunologist, and reproductive endocrinologist who specializes in infertility, implantation failure, and pregnancy loss. He is the principal clinical scientist of Braverman Reproductive Immunology, bringing 20 plus years as a leading authority in reproductive immunology, along with extensive experience in minimally invasive and robotic surgery. As CEO and founder of Pregmune, the first ever immunology-based testing platform that's revolutionizing the treatment of reproductive failure. Dr. Vidali is dedicated to understanding and treating often overlooked causes of infertility and debunking the overused term unexplained infertility. He is also the co-owner and co-founder of the Endometriosis Summit, which connects patients and practitioners in the field of endometriosis. So welcome to the podcast, Dr. Vidali.
Thank you very much, Michelle. It's a pleasure to be with you today. I am actually, I am against the window, so you may see some, when you're looking at me, you may see something in my eyes. I know we are on a podcast, but anybody who looks at the video may see some reflection in my glasses, so I apologize for that.
Oh, no worries at all. And I'm very excited to have you on today. I'm actually really excited to pick your brain on so many things because, of course, I work in fertility acupuncture, so it's a little bit different. It's another angle. And what you do to me is so fascinating because you really specialize specifically in immunology. There's so many questions that people have. And you also talk about unexplained infertility. And before we even get to that, which I'm very excited to get into, I'd love for you to share your background with the listeners.
Well, I am by training, I am a reproductive endocrinologist. I train in gynecology and then did a fellowship in reproductive endocrinology at Columbia. And I was a sort of, let's say, I want to say traditional, if you will, IVF doctor for many years. As I was working in IVF, I developed a marked interest in the field of immunology. Like many doctors, at the beginning, I was skeptical because obviously one has always to be skeptical of relatively new fields and new ideas, and sometimes everybody's resistant to new ideas. But I was introduced to reproductive immunology about 15 years ago. And then started working with Dr. Jeffrey Braverman, who was unfortunately, he passed, and he was both a partner and a friend. We worked together, and started doing research and more work in reproductive immunology, and progressively our interest evolved, our practice evolved. And we became less of sort of like traditional IVF doctors and more focusing on the immunology part of it. And, now basically I don't even do IVF anymore. I just advise patients on what happens whenever they encounter reproductive problems. Mm-hmm. And when I say reproductive problems, I mean recurrent pregnancy loss, of course, failed implantation with IVF, especially with PGS normal embryos, and of course, just general infertility problems, endocrinological. I'm also a reproductive surgeon. Many people also know me for that. So I basically am a troubleshooter. I always look at things holistically, which is a little bit of what you do as well, I think, mm-hmm. right? Whenever you're looking at a problem, you try to address it holistically, and as opposed to just focus on one area. A person is not a uterus. A person is not an ovary. A person is a whole thing. That. And that's how we look at it. Yes. So that's who I am. And I'm excited to be here. I also am the founder of a new company called Pregmune, where it's Pregmune. And we have developed a testing panel that then we analyze, and we facilitate this work of analyzing immunology for doctors so people can have their own doctor look at this stuff. And so
that's
that's what
great.
we do.
That's wonderful.
Yeah. Yeah.
And yeah, I mean, I have so many questions for you. Listen, I have, I work with people who are trying to conceive a lot,
Of course.
and
I
then
know who you are.
I finally get them to conceive, and then there are times, unfortunately, they'll have pregnancy loss, and then sometimes we see that it's not just one time, it happens again, and that's when we really want to figure out what is causing this to happen. And this is the kind of questions I have because, of course, I can, even with fertility, there's kind of like general, you learn a lot of different things. And then, just like you did IVF for a while, but then you focused really specifically on that. And it's a very fascinating topic because one of the things that I was reading that you were saying, it's also implantation failure. So you don't even get to that point of pregnancy and you don't even realize why. And it could be something going on before it even happens. So there's so many different aspects. So we can start with that.
Let me just first say that, and I say this, I always repeat myself a lot on this specific concept, but people have a hard time accepting unexplained as a reason, right? I think that for the longest time in medicine, we tolerated when a doctor would tell you, oh, the problem is unexplained. Mm-hmm. But I think today, with the advent of greater communication at the level of the internet and social media groups and social networks, people don't accept unexplained anymore. They want to dig deeper. Sometimes they dig deeper on their own by doing research via social media, whether it's Facebook, Instagram, and whatnot. And those are very valuable resources because you extend your knowledge. Mm-hmm. But also when they go to experts like you or like me, they don't accept that unexplained anymore. They kind of want to look for answers, and they get turned off when a practitioner tells them it's unexplained, keep on trying and don't worry, that kind of stuff, kind of like a paternalistic attitude towards the problem. Mm-hmm. So when is it that our antennas go up, which is the first part of your question? When we talk about pregnancy loss, the antennas go up, first of all, whenever there are multiple pregnancy losses. Mm-hmm. That's one obviously thing, because one pregnancy loss could be attributed to a random event, a genetic event, and right. Actually that's the most common cause. But when it's repeated, it's less likely because you have to, at some point you have to say, wait a second, is there something going on?
Yeah.
And the second part of it is, is it a pregnancy loss from where a genetic testing was done on the embryo and they found that the embryo was genetically normal? That's mm-hmm. the second part.
Right.
And that's another flag because there's a loss of a genetically normal embryo.
Right.
And the third part is it a loss after an IVF where the embryos were also tested before putting them in and were they abnormal with the testing? So that's mm-hmm. the third part that it becomes a red flag for me. The fourth red flag is a little bit less defined, but it is whenever there is a loss, although we don't know the genetics, but the pregnancy had gone on and a heartbeat was seen. Mm-hmm. Because whenever you see the heartbeat, the likelihood of the pregnancy to be genetically normal is higher. Mm-hmm. So, there's still a possibility that it's genetically abnormal. It's not 100%, but in general, that's the fourth red flag that, makes me say, hey, what else is going on? Mm-hmm. From the implantation failure perspective, obviously, today, IVFs have become such a major endeavor, right? Because most centers now do frozen embryo transfers. Mm-hmm. So you have to do your retrieval and then freeze the embryos. And then they do all the testing to see if the timing is right, ERA and whatnot, just try to... Then they finally do the embryo transfer. By the time you do the embryo transfer, sometimes 4, 5, 6 months have gone through. On top of this, sometimes the embryos get tested, not always, but at least sometimes in older patients, but also in younger. So that also, adds additional time. Sometimes, there's always the required delay. So you're looking at 6 months. So there's so much vested in this embryo transfer because you put so much energy, and I'm not talking I'm talking, of course, financial energy, but mental energy, psychological energy, time energy, and then finally do the embryo transfer and it doesn't work. So it's not just like, hey, one transfer didn't work. This is like 6 months of your life
Yeah,
gone
totally.
into this, and now it didn't work. And patients are thinking, what the heck? I
Right.
just did an embryo transfer that took me 6 months. What if I tried on my own 6 months? Maybe I would
Right.
have had a similar
Right.
chance.
Yeah.
So it kind of, in a way, a little bit in the patient's mind. I'm not saying it's correct, but in the person's imagination, it devalues the value of doing IVF. People are like, what are we doing here? So because of the way IVF has changed today, and there's so much more time requirement, there's a greater desire to figure out problems, to just get to the bottom of the problem and try to be more proactive in figuring out the why, and not accept unexplained, try
That's
again
right.
as
Yeah.
a good answer. People are like, I just want to, honestly, if I'm going to do another embryo transfer, or even if I'm going to do the first embryo, I want to make sure that everything is okay. Which
Yeah.
means also, I want to make sure my nutrition is okay. I want to make sure that my body is in good balance. It's not just the immunology part of it, but of course, that's the part that I do, and of course, we can talk about it now. But
Yeah.
I think that's what prompts. Those are the big sort of risk conditions. And of course, we also add endometriosis to the whole thing because that's a factor that often gets ignored. But yeah,
Yes.
so that is really what the red flags are, that you just asked me about.
Yeah, absolutely. And another question is, God, I have so many questions for you, but I have to say you're a breath of fresh air because you hear a lot of stories, and I hear a lot of stories from my
Thank you.
patients because a lot of times they don't get the answers that they want, and I think that every practitioner, every doctor really does their best. They really do want to do their best. But it's nice to see when they take that extra steps or a couple of steps to really dig deep and not just say, okay, it's unexplained infertility. I don't know what's going on. I'll see you later. Figure it out. You know what I mean? It's kind of like they get so frustrated
Let's
because they
go.
don't know what to
Yeah.
do, and it's nice to see that more is being looked at because more can be looked at, and as you do, you can find things that will make everything make sense than just being like,
Yeah. I
okay.
would like to say that, yeah, that's true. I like to say we're not here to doctor bash. I think every doctor, including myself, including you, we
Mm-hmm.
all have our own biases in the way we
Mm-hmm.
see things.
Yeah.
Okay. And I'm not saying that my biases are my own biases, my own knowledge biases, the way I look at the literature. Your biases are your own biases, your own cognitive biases, your own
Mm-hmm.
knowledge biases, your own selective, selection of the literature and picking what you think is valid and what it isn't. This is part of being human, and unfortunately, we are not artificial intelligence machines, at
Yeah.
least not yet. Maybe in a few hundred years. But the bottom line is that we have to accept the limitations of ourselves as humans and also as practitioners.
Mm-hmm.
But I feel that I agree with you that sometimes it's worth getting another opinion, or at least talk to your doctor and say, look, I'm considering looking into this, and I want you to be part of me, of this journey with me. I think it's the one situation that I feel sometimes creates negative energy for a patient is the eye rolling, saying, "Oh, you know, another one of those." Like, I think that it's important for the patient to understand that you're vested in their care
Yeah.
and that you are willing to listen. I think that's really the most important part. I think willingness to listen, and
Yeah.
we all get tired, we all are busy, we all have long days, we all,
Yeah.
but this willingness to listen, I think, is very important.
Yeah, willingness to listen for sure and investigate, and that's, I think it just gives a level of comfort for the patients, and I do see the difference, and I agree multiple opinions is really key because everybody has a different vantage point in that. And so
Correct.
so for somebody who does have endometriosis, for example, this is another question. Sometimes, well, as we know, we don't know, you can't know unless you're doing a laparoscopy. And some people can. So, what are like, let's just say, what are the big red flags besides getting like really bad period pains, what are the red flags that would get people to say, let me look into this. Maybe I do have endometriosis and
Well, endometriosis, we know factually that it's associated with infertility, right? And also recurrent pregnancy loss and pregnancy complications.
Mhm.
The thing is that we don't go hunt for endometriosis in everybody with a laparoscopy. Of
Right,
course,
because it's
because it
invasive.
is an invasive procedure, we need to have a suspicion that the problem is ongoing. Now, what would prompt our suspicion? Well, first of all, there are some symptoms that are unrelated to pain, and they are the infertility, the recurrent pregnancy loss, the failed IVFs, the diminished ovarian reserves. Those are all signs that endometriosis may be present.
Hmm.
And whenever there are no symptoms, we call them, we like to call it silent endometriosis.
Right.
Now, when it comes to symptoms, of course, those are the classic symptoms of endometriosis: the menstrual cramping, the pain with intercourse, the bloating, and the bladder symptoms, the frequency, bladder spasm, and the bowel symptoms. And what's interesting is that because women are, I want to say, are more are they tend to be focused on their fertility, so the pain problem goes on this, in the back, falls in the background.
Right.
And so sometimes they will not talk to the doctor and tell the doctor, hey, I also have these symptoms. And the doctor doesn't ask the question sometimes, so there is no knowledge that endometriosis may be there.
Hmm.
So I think, again, listening and asking the right questions is important. But, those would be the situations where if there is a IVF failure, the diminished ovarian reserve, there is or if endometriosis itself is seen, right,
Hmm.
then you'd have to consider a laparoscopy, and that's really where, and removing the endometriosis does increase fertility. It's factual.
Yeah, yeah, definitely. And then, so a lot of times, and it happens every different ways with different people. Sometimes it can block tubes, sometimes it doesn't block tubes, sometimes it goes on the ovaries and impacts the
Mm-hmm.
eggs. And there's so many different things that I'm just learning about. And also, one of the things that I think about too is with ectopic pregnancy, if there's partial blockage, it could probably influence that, correct?
Yeah, when we talk about anatomically, we have to remember that the fallopian tube is not a pipe.
Mm-hmm.
The fallopian tube is a functional organ with those little feathery endings that capture the egg. So the test that's currently done is the hysterosalpingogram to test the fallopian tubes open or closed, and that's very helpful.
Yeah.
And the doctors will know if they're open or closed, and I think it's a very useful test at the beginning of the workup.
Mm-hmm.
So people will know that that's what's going on. The doctors will know, and if they see a blockage, obviously endometriosis has to be suspected,
Right.
because endometriosis can cause ectopic pregnancy, even though there isn't like a complete blockage, because there's reduced functionality of the fallopian tube.
Right.
And but yeah, I mean, most of the cases that's not a surprise, because I think that most doctors, and even gynecologists who are just starting the basic fertility workup, will order an HSG to look at the fallopian tubes. So,
Right.
but
That's true.
believe it or not, tubal disease is probably a very uncommon cause of fertility problems.
Yeah.
It used to be a very common in the past, but it's not. Today it's really not that common.
Mm-hmm.
And if it's only tubal disease and they do IVF, most of those patients get pregnant very quickly
Mm-hmm.
because they really don't have any other problem. There's just a blockage of the tubes, and that's
Right.
it.
That's it.
You sort of bypass that, and it works, especially if it's due to an old infection, that kind of stuff. It's interesting that tubal disease, even when you look at the SART data, tubal disease is not very common anymore, interestingly enough.
That's interesting. That is actually interesting to hear. And also, what are the different or common types, I guess, not types or manifestations of endometriosis that you see that you can help with fertility? Like, what are some of the reasons why it's impacting? Because not all endometriosis cases impact fertility. So, where does it
Well,
start to affect it?
it's not about, you see, it's almost never an all or nothing thing.
Yeah.
Okay. The way you have to look at most clinical factors in any condition, especially which is a condition that has multiple factors that affect it, multifactorial, is that every factor contributes to the problem in an incremental way. So, it's the addition of one factor plus the other factor plus the other factor that gives the person their own chance, right? It's like when you're looking at somebody, I'll give you another example that is unrelated, but the risk of certain tumors, let's say breast cancer, and you have your family genetic risk factors, plus you have the behavior risk factor, estrogen intake. You have to add all those things, and then you add the risk. The same thing is for reproduction, which is endometriosis is a factor. Is it a factor that's 100% or zero? Mostly not in every case. In most cases, it isn't. But it is an additional factor that needs to be addressed. And that's why it's very, it is disingenuous to believe that there is just one intervention that can solve the problem. Sometimes there is, but you always have to look at things like incrementally and holistically. So one doesn't know what their own chance of success in fertility or IVF success is. You look at statistical analysis, you could go to SART and put in your age, how many IVFs you've done, and blah, blah, blah. And it tells you, well, based on this, your chance of success over 1 year is 67%, whatever that may be. But basically, all those numbers are the result of putting different factors together. And endometriosis has to be regarded as one factor, and that's why we go after it. And the other, and immunology, immunological factors are another factor. Of course, it's not one factor; it's many factors.
Yeah,
because it's very broad.
It is, and it's hard. That's why it's hard to say. But what are some of the different conditions? So one of them could be tubes, but you said that's not really too much of an issue. Another one could be going on the ovaries. When it starts to grow on the ovaries, how can that impact fertility?
There is an agreement or an understanding, if you will, that endometriosis affects egg quality.
Okay.
There is a lesser agreement on whether endometriosis affects implantation.
Okay.
I personally think that there is some evidence that points to that, but it's not as overwhelming as when it comes to the egg quality component. But that's really how you have to look at it. And the reason why there is some debate on the implantation, because there were some studies with egg donors where using the same donor and putting it in somebody with and without endometriosis yielded the same results in one study and different results in another study. So it's a matter of debate how much it affects implantation. My personal bias, and we just talked about biases, is that in some of the patients that were told they did not have endometriosis, in some of the studies, they may have had it, because doctors are so bad in identifying endometriosis lately that unless somebody is truly an endometriosis expert, it's difficult to say today, who did it and were the pictures and was it documented properly. So I have some questions about that, because
for the implantation,
it's certainly a factor to be considered. And certainly I would recommend looking for endometriosis even when there is an implantation problem, not just relied on the egg quality problem.
Right. And then how does it impact egg quality?
It's, the eggs are, it's thought that endometriosis affects the eggs on an energetic level, mitochondria, at the level of the mitochondria. There's actually mitograde testing that one could do on the embryos to look at that. But it's thought that it's really at the level of the mitochondria. There's also another theory is that it can affect steroidogenesis to some levels. And of course, it's known that whenever these are the biological observations, and then you have the visual observations that always you hear the embryologist and then the doctor tells you that they took out the eggs and they looked dark. They looked at the
Mm-hmm.
cytoplasm looked dark.
Mm-hmm.
And that is sort of like an observational thing. It's a morphological thing that they look at, but that's like another factor. So that's really, when you put all those things together,
Mm-hmm.
that is the thinking, yes.
What's interesting is in Chinese medicine, we also have many different patterns. Like you were saying, there's so many different reasons why things can happen, even though you're looking at one thing. So that
Mm-hmm.
is a very holistic way of looking at it. There's so many different ways that things can manifest. And one of the very common patterns is blood stasis, blood stagnation. And blood stagnation always leads to dark blood, like a little darker. Because the reason why it gets darker is because it's stagnated. It doesn't
Sure,
have
yeah, it
that
doesn't
movement.
oxygenate as quickly. Yeah, correct.
Yeah, so it's kind
Well,
of
I would
interesting
say,
to see that.
yeah, I would say that, of course, when you're looking at Chinese medicine, you're looking at a, a more observational type of approach that then, with over thousands of years, with different iterations of adjusting the procedures, that's how they got to their conclusions. But the fundamentals remain unchanged, which is there's no question that appropriate circulation at the level of the implantation is key
Hmm.
in appropriate pregnancy, right? Like whether you look at it from a Chinese medicine perspective, which looks at it more holistically, or where you think of it that microthrombosis at the level of the decidual, the placental implantation site
Hmm.
can create, or a shallow implantation of the placenta, creates a pregnancy that doesn't get adequate nourishment, if you will, and basically oxygenation and support. It's basically the same way of looking at it.
Yeah, it's kind of interesting, and I love when we can see it show up the same thing in Western and
Mm-hmm.
in Eastern medicine. It's cool for me because like I learned it from here and then I hear it here and I'm like, oh, there's definitely a bridge. And another thing that I was gonna ask you is how do you see that like doing surgery, and I know that every case is completely different, impacts fertility?
Well, there's studies that large randomized prospective studies that show that surgery for endometriosis impacts natural fertility.
Mm-hmm.
When it comes to IVF, there is, believe it or not, less studies.
Mm-hmm.
And I think it's because there's not, there is, the population studies are a little bit more complex in the sense that it's a little harder to design these studies and do them really randomize them properly
Mm-hmm.
because you're looking at an IVF patient, different protocols, different who's going to get the surgery. How do you really randomize it? You do a surgery and then you do nothing
Mm-hmm.
because you always have to compare it to doing nothing, right? If you're
Yeah,
really going to do a right study.
right.
So somebody has to have a laparoscopy where you just look and you don't touch it.
Yeah.
So they've done that in for natural fertility and minimal endometriosis, but
Mm-hmm.
it's very hard to do a study where you do a surgery in somebody and then you tell them, I'm just going to look, but I'm not going to fix the problem,
Yeah, yeah, of
and you're going
course.
to
It's
randomly
it's
be assigned to an arm where we're
challenging.
going to do nothing.
Yeah.
And, it's a tough one. It's a tough one for somebody who's gone through. I mean, it's a tough one in general medicine to do randomized trials, but in most randomized trial, you're randomized to the standard of care, which is whatever that standard of care is. It has a valid thing. In this other case, you're having just a diagnostic surgery where people do nothing,
Mm-hmm.
and you end up a surgery with, if you are in that arm, so it's very hard to do those studies because people, if they have endometriosis, they want to take it care of. They don't want to be a guinea pig in a study.
Of
And
course,
look,
of
studies are
course.
important. I'm not
Yeah.
saying there's enormous value to that. And so this guinea pig thing, I shouldn't have used that term actually, but let's just say that people are not as altruistic, although they understand their contribution to science is important, they also they want results.
Mm-hmm. Yeah, absolutely. Another thing too is, I wonder how estrogen in the IVF impacts endometriosis, getting
It
excess.
impacts it enormously. It
Yeah.
impacts it enormously because I see on a daily basis patients who have had mild endometriosis, and then they did an IVF cycle, and then they start having aggressive symptoms, pain, and all sorts of problems. So it's something that is very, very, very real, and so it's a fact. There's nothing to say that we see this all the time, and so it is certainly something that that it's undeniable. And sometimes people discover they have endometriosis just because they do an IVF cycle.
Wow.
They're fine until they do IVF, and then next stimulation of the high estrogen levels. And, I know it's just a month, but, it is what it is. It's a fact. And really, it's not a month, because you got the stim part, then you have the embryo transfer part. Lots of estrogen, exogenous estrogen at very super physiological levels. And that's enough to just start a certain mechanism of activation of the endometriosis that then are irreversible. Also, I would like to mention, before we move on to talking about immunology, as we have limited time, is that I'd like to mention that there is an organization called the Endometriosis Summit, where I am a co-founder along with Dr. Sally Sorrell, where a lot of this information is shared, and we do have meetings and conferences. And that if you're interested in that, you could check the endometriosissummit.com, www.theendometriosissummit.com. It's a lot about endometriosis, and I think there's a lot of information there, and there's also a conference that we organize. So for your followers, it's something that also may be interesting to know about as a resource.
Yeah, absolutely. And the topic is so fascinating, because I feel like there's so many different things that intertwine or are very connected. And immunology is one of them, like autoimmune conditions and endometriosis. And it's something that they didn't realize at first, but they're starting to kind of piece it together and notice that there is a correlating factor.
There unquestionably is. Like, you always have to think of, like I said earlier, of the body holistically. And why do some people develop endometriosis and others don't? Of course, there's genetic risk, but there's also, of course, immunological risks and progression of disease. And that means that at the level of the body, the surveillance, for this growth has gone down, immunologically speaking. And there's pretty significant data, especially coming out of the Netherlands and Denmark, looking at long-term patients with endometriosis, and knowing that these patients have associated conditions like Crohn's disease, inflammatory bowel disease, and rheumatoid arthritis, along as with other autoimmune conditions. So there are clear associations between the presence of endometriosis and autoimmune conditions.
Yeah.
As there are correlations between immunology, autoimmunity, and reproductive issues, miscarriages, pregnancy losses. And that's where, a lot of my work on, reproductive loss related to endometriosis falls.
Right. And also, so we actually talked earlier on when you were saying that once the heartbeat is heard, it actually reduces the likelihood that there's any issue with the DNA. And so if that does happen, if people have recurring pregnancy loss after hearing the heartbeat, what could that mean? I know there's many different things, but what are some of the things that come to mind?
Well, first of all, whenever there's a pregnancy loss, one should always try to get the genetic testing done, no matter what.
Yeah.
That's essential, and there's different companies that do it. Natera has a kit. There's all different, companies that do that. Number one. Number two, with regards to what are the potential immunological causes of reproductive loss, whether it's implantation failure or miscarriage, you have to look at it from the perspective of what the embryo actually is. You always have to remember that the embryo is naturally, genetically foreign to the body of the mother, because it contains a 50% of the DNA of the other parent. So because of that, there are certain mechanisms in place that prevent the body of the mother to reject the pregnancy. And this process is called tolerance. And tolerance can be developed over time. Whenever a pregnancy is achieved by intercourse, people have sex, right? And the sperm enters the body, and the body of the mother gets habituated to exposure to the sperm, and that can induce some level of tolerance, which is a complex mechanism. I'm not getting into the details of that, but that's one way where that happens. Mm-hmm. Sometimes, because of the genetics of the parents, this tolerance doesn't develop as well. Mm-hmm. And it's the same reason why you could put a kidney in somebody. When you do a kidney transplant, you have to find the right donor, right? Mm-hmm. It's less specific than that, right? It's not as bad. Otherwise, there would never be any babies on the face of the earth. But mm-hmm. to some degree, there's some of that. And that's combined with a natural tendency towards autoimmunity on the maternal side. Mm-hmm. And it's not said that autoimmunity always causes pregnancy rejection, but it is associated with that. And when I say, some red flags of autoimmunity are, for example, thyroid disease, mm-hmm. which is, I'm sure that you see mm-hmm. tons of it. And, but, there's other autoimmune conditions that somebody may or may not know they have, because it's never been looked into. And some people are very asymptomatic. I diagnosed somebody today with a pretty significant autoimmune condition, and she was completely unaware. And, I was just talking to her doctor right before we started talking, and we were discussing how valuable it is in people who've had multiple failures, and how valid it is to look into the immunological part. And this is what we do at Pregmune. We look into that, and we help doctors and practitioners gather more information and a deeper understanding of how that could be. And of course, that also helps on the nutritional side. I mean, you do nutrition. If there's a lot of inflammatory changes, maybe that's an opportunity to try to make some corrections there too. Mm-hmm, and sure. When you talk about autoimmunity, you also talk about inflammation, and those things go together.
Yeah. Oh yeah, for sure. And we could see it, for nutrition and working a little bit more holistic perspective, but it really mm-hmm. makes a big difference.
I would agree with you. I think that whenever you talk about immunology or autoimmunity, you have to look at the nutritional component, because the gut is ultimately an interface between us and the outside world. Mm-hmm. Anything we put in our body ultimately affects us nutritionally, calorically, and but also it affects us on an inflammatory way. Mm-hmm. And sometimes what we eat or other conditions cause dysbiosis, cause alteration in the gut, cause also, and these alterations then are reflected on a systemic level. Mm-hmm. With systemic inflammation, and this systemic inflammation then in predisposed individuals can result into fertility problems or worsen fertility problems, mm-hmm. or worsen increase the risk of miscarriage.
Right. Yeah. It's crazy. And it could be just one or two ingredients or something that doesn't agree with mm-hmm. a person. And then it causes a whole host of problems. And even if you're eating good foods, it won't even process if your body's like responding so strongly to something. So it's definitely an interesting.
Yeah, I don't know. You're telling me something I don't have a full understanding of. Like how, I always think eating good food is good, but maybe it's possible that if your gut is so messed up, then it doesn't matter what you're eating, that you're beyond the point of that you need to do more to adjust it, I guess.
Yeah, well, meaning like your body's not going to even absorb the good stuff if you don't get rid of the bad stuff or the stuff that's causing the inflammation in the first place.
Correct. Absolutely. That's exactly how it is.
Yeah. So, I mean, I could talk to you for a long time. I still have
I think we only have another 7-8 minutes because I have to get on to another call, unfortunately, and I do apologize to you.
No worries at all.
But we could do it another time, talk more, of course, like there's no question about it.
Yeah, I think so. I
guess we could wrap up at least this conversation today. Is there any question that you have, like a specific thing or more very pointed thing that you like to, me to address? Or
But I think what we'll do is we'll have you come back on and we'll
yeah,
talk about something else because I
love to
feel
do
like
that.
there's so many different things that we can talk about, and
There is,
it's
and I
so
love talking
important.
to you. What I like to say though is that people who suffer from pregnancy loss, I just like to say sort of like a philosophical point, which is uh, pregnancy losses or even implantation failures are always dismissed as, oh, it happens. And people are not validated in the suffering that they go through.
Yeah.
Because you can say, yeah, no big deal, it's a loss, it happens, many people have it. And this lack of validation, I feel, hurts.
Mm-hmm.
I feel that it is a form of gaslighting. I know it's a popular word that we use a lot now, but
Yeah.
it really is a lack of validation, I feel, of your suffering because of so what, it happens. I
Mm-hmm.
think that it's important that us as practitioners understand and respect the suffering that people go through with these events. And just because as doctors, as practitioners, we see them every day ourselves in our offices, that doesn't diminish the drama that gets lived on the home front.
Mm-hmm.
And I think, I would like to conclude with that I think if there's an appeal that I like to make to doctors and practitioners is that to have respect for these events that, they seem like minor comparatively in the big scheme of things to compared to some other bad things that can happen to people, but they instead are quite major.
You are so right. I think that is really a wonderful thing. And uh, I really appreciate the compassion that you have. I feel it. You can really feel it from you. The
Thank
compassion
you.
that you have with the baby, you could just feel it. And that's why I said you're such a breath of fresh air because you can feel it. You really can. It's important. Obviously, it's great because you're very knowledgeable too, which to get the combination is not always,
Thank you.
it's a wonderful thing. So I really appreciate that. And I can see how passionate you are. And for sure, I'll be having you come back on because I know that as soon as we get off, I'm going to have a million other questions and we're going to have a whole
and,
other.
and I'd love to sit with you again and talk more about what we do. If people want to find us on Pregmune, it's www.pregmune.com, Pregmune.com. And of course, I can, it's also on Instagram, and you can look up my name on Instagram if you're
Yes.
looking for me. And looking forward to see you again. It was really a pleasure.
Yeah, it's a pleasure. And I'll have all the links in the episode notes if anybody wants to look for that and find it, your website, your social media links, everything. So thank
Very
you
excited.
so much. Thank you so much for coming
Michelle,
on
thank you
today.
so much. It was a pleasure. Okay, take care.
So that concludes today's episode. You can find all of the links mentioned on the episode notes. If you're enjoying these episodes, please take a moment to share and leave a review. Reviews mean everything to podcasters, and I really enjoy hearing from my listeners. You can also find me on my website at www.thewholesomelotus.com or email me at info@thewholesomelotus.com. I love hearing from my listeners. If you're interested and want updates as well as a free ebook on my top 10 fertility boosting habits, you can visit my fertility page on www.thewholesomelotus.com. I thank you so much for listening in and hope that you have a beautiful day.